This is a summary of the Medicare MSSP Accountable Care Organization 33 quality measures as presented by the Alexian Brothers Accountable Care Organization. ACO 18, Screening for Clinical Depression and Follow-Up Plan. This is the percentage of patients aged 12 and above who are screened for clinical depression during the measurement period using an age-appropriate standardized screening tool, and if positive, a follow-up plan is documented on the day of the positive screen. Use of a valid and standardized tool is imperative, though there is not one defined tool. It would not be considered satisfactory to make random statements about patient sadness or stress level. Acceptable screening tools include PHQ-A, CESD, the Beck Depression Inventory, PRIME-MD PHQ-2, and PHQ-9. Exclusions to this metric include an active diagnosis of depression, patient refusing to participate in the screening, or some other medical reason for not screening. The follow-up plan may include additional evaluation or suicide risk evaluation, pharmacologic intervention, or referral to a specialist. ACO 19, Colorectal Cancer Screening. This is the percentage of patients aged 50 to 75 who received appropriate colorectal cancer screening. Appropriate screening includes fecal occult blood testing performed during the measurement year, flexible sigmoidoscopy performed during the measurement period or the 4 years prior to the reporting period, or colonoscopies performed within the past 10 years. The documentation of the date of the screening and a copy of the result need to be accessible in the chart. The only exclusion would be a history of total colectomy or a history of colorectal carcinoma. Newer tests such as Colovantage or newer stool DNA testing do not satisfy the measure at this time.
ACO 20, Breast Cancer Screening. This is the percentage of women who had a mammogram to screen for breast cancer within 24 months. This is another straightforward measure. Women ages 50 to 74 should all have a screening mammogram. To satisfy the measure, the date of the exam and a copy of the report need to be available in the patient chart. The only exclusion to the measure is a medical reason for not performing the exam, such as a female with a history of bilateral mastectomy. ACO 21, Screening for High Blood Pressure and Follow-Up Documented. This is the percentage of patients aged 18 and older who were seen during the measurement period who were screened for high blood pressure, and a recommended follow-up plan is documented based on the blood pressure reading as indicated below. This measure sets parameters for following blood pressure in a patient not diagnosed currently with hypertension. The following are the criteria and the follow-up parameters. For a blood pressure with a systolic of less than 120 and a diastolic less than 80, no follow-up is recommended. For a systolic blood pressure greater than or equal to 120 and less than or equal to 139, or a diastolic of greater than or equal to 80 and less than or equal to 89, rescreen the blood pressure within 1 year and recommend lifestyle modifications or refer to an alternative provider or specialist. For a systolic blood pressure of greater than 140 or a diastolic greater than 90 at the first visit, rescreen the blood pressure within 1 day and 4 weeks and recommend lifestyle modifications or refer to an alternative provider or specialist. For a systolic blood pressure of greater than 140 or a diastolic greater than 90 at the second visit, the parameter suggests recommending lifestyle modifications and one or more second hypertensive reading interventions or referring to an alternative provider or specialist. The goal is to document appropriate follow-up for blood pressure findings. CMS guidance states that appropriate documentation of follow-up recommendations according to the above parameters would satisfy the measure. Second hypertensive reading interventions include medication, lab testing, and EKG. ACO 22 to 26 apply to beneficiaries ages 18 to 75 with diabetes mellitus. The 5 metrics make up one composite measure. The ACO needs to achieve a satisfactory level on all 5 metrics to achieve the potential points for the measure. If we miss the benchmark on any of the 5 metrics, we achieve 0 points for the composite. ACO 27 is the sixth diabetes metric and relates to poorly controlled diabetics. Exclusions to all these metrics include pregnancy and beneficiaries who were permanent nursing home residents. This last exclusion does not apply to ACO 27. ACO 22 includes beneficiaries with the most recent hemoglobin A1C of less than 8. Providers would still manage down to an appropriate individual level. ACO 23 includes beneficiaries with the most recent LDL cholesterol of less than 100. ACO 24 includes beneficiaries with the most recent blood pressure of less than 140/90. And despite any potential changes to blood pressure guidelines, this is the ACO goal for this metric at this time. ACO 25 includes diabetic beneficiaries who are identified as non-smokers of tobacco. The goal is to maintain the highest percentage of non-smoking diabetics, which would lower the risk for complications. ACO 26 includes beneficiaries with a diagnosis of diabetes and ischemic vascular disease with a documented aspirin or antiplatelet medication use. If a patient has a contraindication or other reason for not using these meds, this needs to be documented. There are multiple reasons or contraindications for not prescribing these meds, and they can include current use of anticoagulants, history of GI bleed or intracranial bleed, or an allergy to aspirin. This emphasizes the secondary prevention strategy in those with diabetes and a history of IBD. ACO 27 includes the percentage of patients with the most recent hemoglobin A1C of greater than 9%. This would be a group of beneficiaries that would benefit from increased outreach. The only exclusion to this metric is gestational diabetes. And again, ACO 27 is not part of the composite. ACO 28, controlling high blood pressure. This measure gauges diagnosed hypertensive patients with adequately controlled blood pressure less than 140/90. The last recorded blood pressure value in the provider office is counted towards the metric. Home blood pressure readings are not accepted for this measure. There are no stipulations regarding what type of medications are used to achieve blood pressure control. At this point, the metric goal continues to be less than 140/90, despite any possible future changes in blood pressure guidelines. Exclusions include end-stage renal disease and pregnancy state. ACO 29, ischemic vascular disease and LDL control. This measure emphasizes the goal of LDL cholesterol less than 100 for beneficiaries ages 18 and older with known ischemic vascular disease, including those with prior myocardial infarction, CABG, or percutaneous coronary intervention. The most recent LDL value documented is used for reporting performance. ACO 30, ischemic vascular disease and use of aspirin or other antithrombotic. This measure evaluates beneficiaries ages 18 and older with a history of ischemic vascular disease who have a documented use of aspirin or another antithrombotic. The key to this is documentation of aspirin as a medication in the patient's medication list. Clopidogrel is acceptable as an alternative if the patient is allergic to aspirin. Otherwise, there are no exclusions to this metric. ACO 31, heart failure and the use of beta blocker therapy for left ventricular systolic dysfunction. These are the beneficiaries ages 18 and older with a diagnosis of congestive heart failure and left ventricular systolic dysfunction, defined as a left ventricular ejection fraction less than 40% or a reading of moderate to severe left ventricular dysfunction on echocardiogram, who should be prescribed beta blocker therapy. There should be a documented echocardiogram in the patient chart, although an echocardiogram does not necessarily need to be done each measurement period. There are 3 types of beta blocker agents that are evidence-based and satisfy the metric in all doses and all varieties: carvedilol, bisoprolol, and metoprolol succinate. Metoprolol tartrate does not satisfy the measure. Any other beta blocker used would need appropriate documentation as to why it is being used for the purposes of CHF with LVSD. One may defer use of a beta blocker agent with proper documentation of a patient, system, or medical reason for not using, such as blood pressure issues, asthma, or refusal to take. The following 2 measures are related to coronary artery disease and are considered a composite measure. We need to achieve the benchmark for both measures to earn the points towards our score. ACO 32, coronary artery disease, lipid control. This measure tracks patients with a diagnosis of coronary artery disease for LDL cholesterol less than 100 during the measurement period. At least one LDL level must be documented each measurement year. An LDL less than 100 is the focal point, but a documented plan for treating an LDL that is greater than 100 does count in favor of the numerator, and such plans may include starting a statin, documenting recommendations for lifestyle modifications, or a scheduled reassessment of LDL. Exclusions to this measure include a patient, system, or medical reason, including allergy to statin, intolerance to statin, patient refusal, etc., as long as it's documented in a patient chart. ACO 33, coronary artery disease and left ventricular systolic dysfunction or diabetes, and the use of an ACE or an ARB. This measure looks at patients aged 18 and older with coronary artery disease and left ventricular systolic dysfunction or a diagnosis of diabetes. These patients should have a documented use of an ACE inhibitor or an angiotensin receptor blocker in the medication list. The ACE or the ARB may be any within the two classes of drugs. Similar exclusions apply to this measure, including a patient, system, or medical reason, as long as it's documented in the chart. Thank you.